Counterfeit Drugs, presented by the Partnership for Safe Medicines and HealthHIV. While participating, all lines will be mute and the event will be recorded. At the end of today's presentation, there will be a verbal Q&A session. You may also submit a question and answer throughout the presentation by using the question or the chat features in the control panel of the webinar. Once again, welcome to Protecting Clinic Patients from Counterfeit Drugs. At this point, I'd like to introduce our first speaker, James Sykes. As Advocacy Manager for HealthHIV, James provides overall coordination of the organization's local, state, and federal advocacy efforts. James has been involved in HIV since 1994, beginning as a volunteer care and support buddy for a person living with HIV in Atlanta, Georgia. In 1999, he joined the Tampa AIDS Network as a health educator, where he developed and implemented a pilot program designed to increase adherence to treatment among minority clients. James went on to serve as Director of Education for Tampa AIDS Network, where he supervised the community outreach, HIV testing, and community education programs. In 2004, he joined the AIDS Institute, where he served in several capacities, the last of which was Director of Global Policy. Please welcome James Sykes.
Thank you, Deborah. This afternoon, HealthHIV is excited to be a part of this webinar to talk about protecting clinic patients from counterfeit drugs, or any patient from counterfeit drugs, and any consumer for counterfeit drugs for that matter, because a patient, when they're no longer in the hospital under a doctor's care, is a consumer, and we are all consumers of drugs in one form or another, over-the-counter or prescription drugs, and we have to make sure that those drugs are safe. And that's an issue of concern for all of us, and particularly for people here at HealthHIV. And HealthHIV is really putting health first. And we put the emphasis on health as opposed to just HIV, because you can become stigmatized by just the disease and not the outcome that we're trying to seek, that we're trying to put people who are infected with HIV back into a state of health and a state of good health, and to maintain that health over the long term. The mission for HealthHIV is to advance effective prevention, care, and support for people at risk for or living with HIV by providing education, technical assistance, health services, research to organizations, communities, and professionals. Our core capabilities are, we have education, technical assistance and capacity building, health services, research and evaluation, and advocacy. And of course, I am the advocacy manager, and we talk about global, domestic, and federal advocacy efforts, be it people living with HIV globally, folk living with HIV here locally in the DC area, or folk here within the country. Those issues, and those issues that pertain to those people. We are a diverse staff of 19 with HIV clinical, global, and cultural competency and prevention experience. I've got over 15 years myself. There are many more here who've even more years in the field. And we have numerous strategic partnerships with national and local organizations, be they nonprofit, clinical, or technological organizations. And what you should see now is a HealthHIV core reach paradigm, and it shows you HealthHIV within the core, and our outreach to community and faith-based organizations, HIV specialists, primary care providers, our online communities via blogs or text messages, a program with U.S. mayors, our Ryan White program, and other HRSA grantees, and that's Health Resources Services Administration, as well as AIDS service organizations and family planning clinics, and community health centers, which is our primary focus, since we are the National Center for Health HIV Care in Minority Communities. That's a lot of words, but that's the AIDS Educational Education and Training Center designation for our outreach with the community health centers and providers in those centers. And so why is drug safety an issue for us, or of concern? Well, for people living with HIV/AIDS, drug safety is an issue primarily due to the potential for drug resistance. Drug resistance is the reduction in the effectiveness of a drug. Counterfeit or substandard drugs can have too much of an active pharmacological ingredient, which can result in an increase in side effects and intolerability, and which leads to a decreased adherence and compliance among patients. Or it can have too little of the active pharmacological ingredient, which leads to increased activation of the HIV virus, resulting in an increased viral load, a decrease in the CD4 or T cells, and then which ultimately results in increased morbidity and mortality for people with HIV. An increase in T cells and a decrease in T cells, an increase in viral load. That means more T cells are being destroyed, resistance is being lowered, opportunistic infections is more possible, also decreased state of health and also survival over time. As well as an increased activation of the virus allows for replication of the virus, and the replication of the virus allows for genetic mutations, therefore rendering the virus resistant to that entire class of antiretroviral medications. So the issue is then resistance can cause the treatment, the medications not to be effective, and then that patient has to go and look for another drug, which has to be in an entirely different class to which they've become resistant to, which then also leads to a cost factor. Then adherence also means taking your medications as instructed by your healthcare provider. Being adherent may slow down the reproduction of HIV or help stop the development of drug resistance. The problem with counterfeit or substandard drugs is that the patient can be adherent and compliant, but most likely not experience the expected benefit or outcome. And so, again, that affects the morale of the patient, their willingness to be adherent and compliant, and then not to see any health outcomes, and you see a deterioration of the health of these people, and you not know why until there's some resistance testing done to find out that the cause was the medication itself not being in an effective dose. And so, and at this point, I'd like to leave my discussion and why counterfeit drugs and substandard drugs are an issue of concern for people in the HIV community, just to talk about the whole dangers of counterfeit drugs altogether. And it is my pleasure to introduce Dr. Bryan A. Liang. Dr. Liang is the Executive Director and E. Donald Shapiro Distinguished Professor of Health Law, Institute of Health Law Studies, California Western School of Law. He's co-director and adjunct Associate Professor of Anesthesiology. He's at the San Diego Center for Patient Safety, the University of California at San Diego School of Medicine. He's adjunct Associate Professor of Public Health, Global Emergency Preparedness and Response Program at the Graduate School of Public Health at San Diego State University, and Adjunct Professor of Aviation at Western Michigan University College of Aviation. And he also serves as the Vice President for the Partnership for Safe Medicines. Dr. Liang's research and advocacy focuses patient safety and access to care. He has published and spoken widely on the topic of safety and vulnerability of the drug supply, with more than 300 publications and presentations in domestic and international public and private forums. He received his Bachelor of Science from Massachusetts Institute of Technology, a doctorate from the University of Chicago, a medical degree from Columbia University College of Physicians and Surgeons, and a law degree from Harvard Law School. And so without further ado, and what an impressive resume, it's my pleasure to introduce to you Dr. Bryan A. Liang. Dr. Liang.
Thanks, James. It's a privilege to join you and HealthHIV in this webinar. Actually, the most important thing about my background is that I don't, that's a lot of degrees, but I'm an expert in the student loan program and probably bankruptcy too. Now, what I want to really emphasize here, and thank you, James, for those introductory remarks about HealthHIV. HealthHIV is truly an effective coordinated public-private partnership, and it's really served as a model for advocacy for vulnerable patient populations like the HIV/AIDS populations and other populations that need some kind of help in getting some of these issues, importantly, in front of policymakers and the patients. As well, of course, we want to educate our providers and our community clinics to see some of these concerns. So that's actually why we're here today, to work with and think about vulnerable patient populations and counterfeit drugs, but also try to expand that to say, you know, HIV/AIDS is an important populace, but we need to expand that even further to make sure that all vulnerable patient populations actually do get the benefit of understanding what the problem is and how we do something about it. So let's talk about these key issues of drug safety. First, in this, hopefully this will work. Okay, great. First and foremost, as we all know, we love drugs. We love them, we love them, we love them. We have a lot of benefits from pharmaceuticals, increased longevity, cancer survival, HIV, AIDS survival. All of these things have been assessed. All of these things have been pretty well formulated as a determinant of efficiency. When we think about investment in treatments, we think about how we do these things in the United States and actually around the world. When you look at these critical areas, longevity, cancer survival, and AIDS survival, doesn't matter where you look around the world, pharmaceuticals actually are a very high benefit, very favorable cost-benefit ratio in terms of improving quality of life and obviously longevity. Obviously as well, economic benefits, reduce lost work days, on both kind of subpopulations and population bases. We're seeing really good effects. So we really like drugs for a good reason. And from a medical care provider point of view, we love drugs because they actually do improve the quality of life of the patients that we have the privilege to serve. So this is something that I think everybody knows. It's an important arsenal for us as people who want to make people better, who want to improve health of our population. Pharmaceuticals are a very high benefit. Now, we use drugs a lot. In fact, 3.7 million prescriptions filled by pharmacists annually. That was last year. The estimate will be more every year. It goes up. About 1.5 million drugs are filled in community basis, including community clinics. More than 139 million drugs are filled through hospitals, outpatient pharmacies. I mean, you can just see on and on and on. These things are just so well used because we actually see the benefits associated with them. So again, you can see, number one, it's very cost beneficial and appropriate thing to use. Pharmaceuticals are great in that sense. We use them a lot, so we actually employ the tool. So actually, these things are two very good policy assessments. We know that it's cost beneficial to use this tool, and people actually use the tool. Now, we also spend a lot of money as well. We're talking about 2009 figures, about $287 billion. In 2015, the estimate's about $446 billion. Hard for me to get my hands around that, so what I did is I actually divided that by 365, and what you find out is this is a lot of money. 1.2 billion a day. That's how much we're expected to spend on drugs for the purposes of improving our health, improving and getting to the goal of the health goals that we're interested in. So we spend a lot of money on this too, and it's this last thing that creates the problem. And the problem is, of course, counterfeits. The benefits to counterfeit drugs for regular drugs only accrue if obviously they're real. Unfortunately, WHO has thrown out a figure about 10% drugs worldwide are fake. Who knows if that's real, but we have research literature to suggest that in some areas of the world, and you're talking about non-traditional places like bodegas and other places to get drugs, you're talking between 40 and 50% of those drugs are being reported as either substandard or fake. And you can see on the left-hand side here, this is a picture from an actual night market, and you can see all of those drugs. I mean, those drugs they're locally made, they're nationally made, they're internationally made. Pretty much anything you want, you can get it. Unfortunately, WHO also estimates that's about $40 billion in sales annually. And again, because I can't get my hand around those kind of big numbers, I think about it per day. That's $132 million a day. That is enough money to probably pay off all the student loans of everybody on this call and their kids as well. So that's a significant amount of bucks. As well, this is a growth industry, and the estimates are that theoretically, if you look at that $40 million sales figure and you increased it by assuming a 1% increase a year, that's $75 billion as of last year. Now, that's probably a vast underestimate about this market, particularly in economic times like this. You see a shift from legitimate economic activity to illegitimate activity, as well for people who are cost sensitive. Same thing, they go from the traditional places to buy to non-traditional places. So that's probably a significant underestimate, the $75 billion figure. This is completely fueled by non-traditional sources. So the internet, importation, bodegas, night markets, all of these things have tremendously pushed the amount of counterfeits that are now in the market, in our streams of commerce. I should also mention that another thing that's really pushing this is the FDA drug shortage. with a tremendous amount of shortage of these very important drugs, it's become very difficult to obviously for legitimate people to access them. Well, that just creates additional opportunities for people who are less than ethical to actually go out and try to sell these drugs. So tremendous amount of, right now, influences creating the kind of perfect market for counterfeit drugs. Now, this has snuck up on us, but it's actually not a new issue at all. You can see there's some examples here that I've given. It's just going up and up and up. The more we look, the more we find. You're talking about everything from cancer drugs, in these low-dose epogen relabeled as higher dose. You got Lipitor in 2003. That actually put a lot of the counterfeit drug issues on the map when roughly about 2 million doses were found to be fake. And you can see it goes on and on and on, all the way till last year. EU, 35 million fakes found in the first quarter alone. You might have seen last week. Now we've got HIV drugs that are found in the regular supply chain in the UK that have been found to be fake. So there are a tremendous amount of challenges right now. And if, again, the more you look, the more you find. This is why Europe has actually moved very quickly in trying to, the Council of Europe is trying to actually address this issue. But they got a few other things like France and Italy and Germany you have to think about. So we got a lot of things to think about there. So that's kind of been stalemated a little bit. But they recognize the problem because they're seeing it directly. Now, in addition to this, it's really not just the Europeans. It's everybody. It's everybody in France. It's everybody in the United States. It's everybody in the European Union. It's all around the world. In the past 3 years, just to give you a sense of the severity of this problem, in the UK, we had 5 Class 1 recalls for fake drugs. Now, Class 1 recalls are the top-level recalls. They're for recalls for products that have a substantial possibility of injury or death associated with that product. So it is not, they're not being silly about this. This is a serious problem, and they have continued to try to pull back a lot of the drugs that you're discovering. You can see other things, 500,000 fakes a day. These guys are verified to be sending stuff to other countries through parallel trade from one country to another, sending the goods over national borders. We don't allow that here. They allow it in the EU. A variety of other things. But you can see this is not just a problem of, quote-unquote, the third world. Or the least developed countries or developing countries. It's everybody. The UK, Netherlands, you can see Italy here, France, Spain. All of these countries have experienced this problem in the past 3 years, and it's just growing. Now, what kinds of stuff are we seeing? Well, back in the bad old days, supposedly it was lifestyle drugs like Viagra and OxyContin. That's never been true, quite frankly. It's been a lot of other things as well. But that's the thing that people have been seeing and say, oh, well, that's the problem. However, that was the perception in the bad old days. Now it's everything else. Think about every other drug you might be interested in: HIV therapy, AIDS therapy, OTC meds, antibiotics, insulin, cholesterol, biologics, cancer drugs. All of these drugs are now being found and seen in the supply chain. And that's a really tremendous, challenging problem because we're, unfortunately, with the internet growing, with the ease of access to medications to both buy and sell, this has become an exploding issue. But philosophically, what the important part of this is, we can no longer ignore this. There was a lot of snickering going on in the early 2000s, and people saying, oh, well, people are getting fake Viagra. Well, first of all, there shouldn't be any snickering at all about that. It's a dangerous thing. But secondly, now that snickering has been silenced, thankfully, because, in fact, we're not talking about just somebody who wants Viagra. We're talking about people who want life-saving drugs as well. And indeed, that is the most important part. If you look at some of the data associated with people who are going to, for example, international websites to look for drugs, these are the senior population. This is not somebody who's just interested in finding free Viagra or easy access Viagra. These are people who need life-saving drugs. So this is not a trivial issue anymore, as it ever was. Now, how good are these guys at doing what they do? They are excellent, outstanding. These guys should be winning awards. As you can see here, very, very difficult to tell the difference between the fake drug and the real drug. And indeed, if you put these pictures, and obviously a lot more, you put these in front of many of the actual manufacturers of the drug themselves, and they cannot tell the difference. It's exceedingly difficult. Even people who have worked in this area for years and years and years simply can't tell the difference. And you can see why. These guys are outstanding at what they do. These are real artists. Too bad they didn't have they put that creativity to something more socially beneficial. But you can see here, very difficult to tell if something's real and something's not. So these guys are very good at what they do. Well, at least some of them are. Some of them aren't so good. And here you see a biologic drug, and you see right inside that biologic, that little dot in the center. That dot in the center, look to the right, that's magnified. That's larvae. So that biologic drug, usually these biologic drugs are highly for very serious conditions, often particularly being used for immunocompromised patients and other patients, HIV/AIDS, chemotherapy patients, and so forth. They're getting injected this directly into their body. So a fly larvae is not necessarily the best thing for an immunocompromised patient to have in their body, injected directly into the venous or, in some cases, other parts of their body. Not a good situation. So this is a significant problem because people who are making these fake drugs don't give a hoot about the patient. All they care about is somebody to pay for this so that they can get their next bits or their next set of profits for whatever they want to do, their criminal operations. So really important to realize quality assurance is simply not there. Now, how easy? Pretty straightforward when you're talking about making drugs. Let's just talk about Vioxx. Clearly and cleanly been off the market for years now. Clearly and cleanly been considered to be, should be withdrawn. Merck has the worldwide patent on most of these drugs, in most countries for Vioxx, for the material. So let's see if we can get it. So what we did is we went on to a business-to-business website to see if we could actually get the materials to start making fake Vioxx. And we got, it wasn't just easy, it was child's play. The amount of stuff we could easily buy on Alibaba.com, which is a business-to-business website. You want the prints, you want the raw materials, you want the presses, you want the things that'll make the packaging. No problem. You, me, a few other people, $15,000, we can create an online pharmacy making this stuff and selling it. So very, very easy to do, and we actually got to the point where we could, right before hit the purchase button, we could order everything we wanted, and they didn't ask for any verification whatsoever, and most of these are from China. Now, how profitable are these activities? Well, as you can imagine, extremely, hugely profitable. On the left-hand side, you're seeing typical drug manufacturing processes and plant. You can see it's very clean. There's a clean room, tremendous amount of technical stuff that has to be involved, putting these things together, making sure that all the quality control is in place and quality assurance is actually done. That's the left side. That's why it costs so much money to make effective drugs. Look on the right. These are actual pictures. These are pictures of actual counterfeit drug operations. And you can imagine that, all the dirt and all the disgusting materials that are in there, well, guess what? That's going into the patient's body. And again, when you're talking about immunocompromised patients, other patients with comorbidities, chronic disease, not going to help their health. Now, in addition, just in terms of the numbers, we have data that suggests that if you could make a fake pill for a cent, you're still selling for 30 cents. So you're making a massive amount of profit. But importantly, this is still cheaper than a legitimate drug. So this is known in economics as a Geffen good. As the more expensive it is, the more people want it. So in this situation, the irony is that the closer the cost of the legitimate drug of the fake one, the better the sales. So in fact, what you're seeing is these people raising their prices during times where, let's say, with an FDA drug shortage or in other circumstances where the drug is trying to be accessed for a variety of other reasons. They just set that price higher, and they see they can get those sales. Furthermore, of course, because it just needs to look like the drug, does not have to function, it makes it cheap to do. Compare that, though, with heroin or cocaine, which a lot of these people used to sell. Heroin and cocaine has to work, or else you don't get any more business. So that's a real problem for people who are trying to make money from illicit drugs. So the easy solution is to that, go to illicit drugs and actually focus on that product, because that product is easier to do and there's no required actual clinical effect. Now, as well, of course, no skilled workers are necessary. You saw the previous slide as to what the conditions are. And really, there is no real effort at detection. Honestly, I've talked to lots of law enforcement people around the world, and it's really difficult to get them to focus on counterfeit drugs, particularly in the United States, but as well other parts of the world, because cocaine and heroin and other illicit drugs are such a huge problem. Unfortunately, the penalties to try to disincentivize making counterfeit drugs are a joke. U.S., roughly less than 3 years for counterfeiting a drug. If you happen to make a trademark violation, that's actually the thing that gets you. You actually get thrown in jail for 10 years, up to 10 years, for violating someone's intellectual property rights. There is nothing there that in terms of public health, danger to public health, you're not getting hit for that, or you're getting very minorly hit for that. In Asia, this is another amazing thing. In terms of the penalties, generally no more than 6 months for counterfeiting a drug. But interestingly enough, when I was there addressing some of the Asian Pacific Economic Coordination community, what they told me about was this negative rent concept, that you don't even have to serve the time. You can just pay for the cell to be empty. And therefore, in fact, people actually don't serve time for doing this in many places in Asia because of this paying the cell to be empty thing, and you're never really getting to the bottom anyway. In another example, South America, you get 10 to 15 years for cocaine and heroin dealing, and this is a big progress and a joint U.S. policy and South American policy for a variety of countries to try to really crack down on the illicit drug trade, and they have. Unfortunately, they've not gone the other direction, which is crack down on the illicit counterfeiting trade, and that still goes on, less than 6 months once again. In a few days, you're out on bail. So really not a tremendously effective system to try to keep things safe around the world so far. Now, how does this risk actually manifest itself in the United States? Well, in the United States, we actually have pretty darn good drug supply safety. About 90% of the drugs go through a simple system. They go from the drug manufacturer to one of the 3 large wholesalers, and then directly to the retailers, in other words, pharmacists perhaps, or hospitals, the end point where it gets dispensed to the patient. And this is a very tight system. However, 10% of the drugs in the United States actually go through something called the gray market before the final pharmacy and patient. Now, the gray market is where secondary wholesalers sell the drugs, and drug resale occurs. Resale occurs between most of the 3 major wholesalers and the 6,000 secondary wholesalers. Now, theoretically, this has been kind of washed out. We don't do this a lot anymore, but it still does exist. You still get a lot of trade on the local level with these secondary wholesalers. And there's some good reasons for that. You want to shed excess supply, you want to arbitrage prices, address cash flow issues, expirations, big, huge concern. And in the United States, we allow repackaging of drugs. So we see a lot of hands touching these drugs as they go through different levels, different secondary wholesalers to the primary wholesalers, getting back into the market. The packaging gets changed. A lot of this stuff happens on the fly. Now, the problem with that is if you have a lot of people touching these drugs and we allow for repackaging, you're going to see counterfeits enter into the system because it's so easy to do. No one has the ability to check each and every single transfer. So there's a big vulnerability here with respect to counterfeits. And here's an example of how the gray market works. This is from the book Dangerous Doses by Catherine Eban. She actually exposed this problem of the gray market in terms of the risks of counterfeits and substandard drugs in the gray market in her book Dangerous Doses that came out in 2003, 2004, I think. And it's an excellent read if you ever wanted to get more information about this. So her exposure of the gray market here was important because it exposed to the world, the broader community, that there's a real problem with some of the gray market trade here. And you can see, for example, you may not be able to see this on your screen, but in the center here you see the gray market, and that's where the trade started to happen outside the traditional, strict, really robust channel. And right in the center you see a little square that says Playpen South Strip Club in Florida. That was one of the places that the drugs were being traded through. So you could tell gray market is not necessarily the best place for you to probably get your drugs if you can't really determine exactly where they came from. So real challenge of the gray market. And then many of you probably have also heard about the gray market because of the FDA current shortage. Unfortunately, the FDA is trying to work on a very difficult problem, but we're also seeing reports of these gray market people going back to the gray market to try to get these drugs because it's a shortage situation. They know the risks, but they're going back there anyway. Unfortunately, we just have to address that issue. A lot of problems going on with the gray market now. Suffice it to say, it's not the safest place to procure your drugs. Now, who's doing this? Who is actually engaged in these kind of criminal activities? Well, first and foremost, it's not legitimate small business. We're talking about organized crime involved in a lot of the counterfeit trade in the United States as well as around the world. Here's some examples here with DEA. The FDACI did a great job, 124 arrests, seizure of 56 steroid labs around the U.S. a few years ago. More stuff here with the federal grand jury. As well, there's been several coordinated international efforts under the rubric of something called Operation Pangea. We have a lot of efforts to try to address particularly the internet sourcing of these counterfeit drugs. Importantly as well, there have been ties to terrorism. There was a U.S. Joint Terrorism Task Force a couple of years ago, found out that a lot of the profits were being transferred to Hezbollah, at least with some of these profits. And then the House Subcommittee on Criminal Justice, they came out with a great piece of information about how this could happen. So there's a Taliban strategy. You're going to send white powder around to make a fake anthrax scare. Now, anthrax is generally treated by ciprofloxacin, which is a specific kind of antibiotic, quinolone. So they were going to set up pharmacies, online pharmacies, to sell the ciprofloxacin. And once the powder started to go all over the United States, there would be a scare. People would go to the internet and buy ciprofloxacin. Well, unfortunately, the idea was that the Taliban would actually have pharmacies sell poison to these people who are buying the Cipro to protect themselves. And the concept here was it's a very elegant jihad because the West funds its own demise. This was obtained, this information was obtained, again, through the subcommittee. So you can see this stuff is not passed by those people who want to make money for really nefarious activity, including terrorism. It's not just about profits. It's about actually harming other people. So a lot of people who are engaged in this. As well, as I mentioned before, there's a little bit of organized crime here, and indeed, this is a couple of our colleagues who actually engaged in this. Domino Gonzalez and Julio Cruz, they were convicted South American drug lords. They had already been thrown in jail for cocaine selling, for being dealers in cocaine. Well, subsequently, they got thrown in jail because they were caught. Because they actually were in jail together. These people didn't know each other until they got to federal prison. Once they got to prison, they came together and said, what did you get busted for? Got busted for cocaine. That's too hard of a job. Let's actually come up with a better idea, and that's how they hatched the concept of counterfeit drugs through internet pharmacies. So in prison, we've got these guys getting together and creating a plot to actually go out there and sell drugs using the internet. And they figured illicit drugs, a lot less risky, a lot more profitable. They were absolutely right. Silly them, though. They made over $10 million in sales, but unfortunately for them, they got caught. So thankfully for the rest of us. So this is actually a very outstanding example of how these individuals who were South American drug lords actually shifted into a different business, the illicit counterfeit drug business, because it was just easier to get into and a lot more profitable. Now, what kinds of harm can involve here? You know, James had mentioned some of this earlier. Basically three things: wrong ingredient, wrong concentration or dose, or no ingredient, or / bad ingredient. So if you've got the wrong ingredient, you're obviously being faked by the wrong drug. You're not being treated for the disease. An example of this is a vial of antibiotics that was relabeled with a fake label of another, more expensive antibiotic with different bacterial coverage. So here you are taking an antibiotic. You're thinking you're getting treated for the thing that you have, the bacteria you have, and in fact, it's actually a totally different antibiotic. So not a very good situation. It also increases resistance to antibiotics. Very, very bad for everybody, not just that individual, of course, but the community. Wrong concentration or dose, too high, too low, harms the patient. Another case, cancer patient, needed Epogen. Unfortunately, she got the diluted form, and unfortunately for her, it created problems for her family, and as well, if you don't have Epogen and you're a cancer patient, and virtually every cancer patient gets Epogen because of the low red blood cell supply, and it increases red cells, she couldn't interact with her family. So you ask the question, you know, how much is a week, a day, an hour worth for interacting with somebody, and she can't do it because there are fake drugs on board. That tells us more of the human side of what's happening. Further, there's no ingredient. Patients may be harmed by either not being treated or actually the fake material is being used to try to make the drug look authentic. So, for example, we've got bad stuff like bacterial-laced water that was being used as an IV antibiotic. We had pediatric inhalers. People were using non-sterile water that had bacteria in it, subsequently determined. People were selling these things, and these kids were spraying this stuff, these cystic fibrosis kids, spraying this stuff right into their lungs. Toxic yellow road paint, it mimics the authentic drug, particularly Lipitor in this case, and people just use it despite the fact that there's known problems with these particular things. The counterfeiters don't care. As well, I think some of us have heard of this. A lot of people have heard of this. Antifreeze was substituted for glycerin in cough syrup, and parents were giving their kids literally poison as their kids, and unfortunately the parents very dramatic, very problematic, huge amount of harm that is involved here. Now, in this situation, what do you do about it? Well, from the point of view of the patients and providers, providers in this situation are the last bearer of harm for patients. Now, we should be working with patients. Patients should be working with providers. We as patients always should be working as a team member with providers. But at this level, providers are one of the last barriers to harm. They've got to be knowledgeable about this first so that these people, so they understand what the ramifications are and they understand what they need to do. Critically, education, communication. That's really what has to be done here, particularly for vulnerable patient populations. Now, how can we do some of this? First, talk about counterfeits. It's an open topic. We should be talking about it. It's something that, just like any other risk event, we should be thinking about these issues either as a patient or ask our physicians and nurses, or the other way around. Providers should be knowledgeable to discuss this with patients. From a provider kind of clinic point of view, we really need to ask a very simple set of questions. Are your medications working? Where did you get them? And careful about the internet. Sometimes there are significant problems with the internet, substandard counterfeit drugs. This allows us to open in conversation with patients who may be embarrassed or may have some reticence about discussing with us where they got their drugs. We have to be open. We have to bring the issue up, and we need to be very, very transparent to say, we want to talk to you about this. We want to hear your concerns about this so that we can help address them. As well, we have some good information on, as was mentioned earlier, James said that I was the Vice President of the Partnership for Safe Medicines. We actually put out a lot of free materials, something called the safemedicines.org site. We have email alerts about suspect drugs, no spam, we don't do that. Information on news, ways to save on medications. We have something called the Safe Drug Checklist. This is a checklist that allows patients, they go through it, keep their records, they really will be able to identify either suspect drugs or actually frank fake drugs. And I should mention that in the past 3 or 4 major counterfeit drug discoveries, they were all made by patients. They were all identified first by patients. So we really want to keep them in the loop and really work with them so that they can actually help in getting these issues to the forefront and then hopefully detecting some of these things if in fact they're there. In addition, with respect to this Safe Drug Checklist, this too is available on the safemedicines.org website. You just look and you can just see the checklist, samples, appearance, feel, or taste evaluation. If there's a problem, contact your doctor, remove it, make it unavailable, give details. This as well is available at the safemedicines.org website. Again, all of this is just accessible. We're a voluntary organization, so please feel free to download it, spread anything you need from the materials that you get there to use it for both provider to patient communications and then patient to provider communications and then communications amongst professions and patients. Now, importantly, no matter what we do, particularly we in the healthcare community, no matter what we do, we have to educate ourselves because we have a fiduciary duty to do that. We have an ethical duty to do that because we do have a privilege of being able to help patients reach their healthcare goals. So one of the things that I really want to feature here is a safe sourcing checklist. This is how you actually look at and evaluate whether the drugs that you're getting have suspect signs or are more on the side of being legitimate. And this is really an issue of being somewhat common sense, but importantly, there is a set of checklists so that you have a way of assessing things so that you don't have to memorize all these steps. And then as well, we want people to report if in fact they see problems. So the overview, step 1 through 4. Step 1, avoid the unsafe medicines and vendors. Step 2, detect them. Number 3, report them. And number 4, keep vigilant. So let's look at each of these in order. First, avoid them. So first things first, we have our philosophy is get a established list of trusted sources. The people you've worked with in the past, the people that you felt you can actually trust in the past, and that may be direct or it may be indirect. And importantly, that might be the pharmacists, the people that you work with in the community consistently. And I really emphasize that pharmacists are a critical part of the safety chain here because they are both the gatekeeper of the drugs that come into the system as well as the gatekeeper of drugs that go out of the system to the patient. So really important to work with them, even if you procure the drugs yourself, because they have good information, good techniques. The American Pharmacists Association is very on top of this issue. So get that trusted source list, acquire a copy of the source's license. So we have distributors and wholesalers in the United States, particularly the big issue. The National Association of Boards of Pharmacy, NABP.net, they have a list of these things, these organizations. Go to that regulatory list because it's there for your benefit. Use it, reuse it, make sure people actually are on that list and legitimate. In addition, make sure the form is right. So a list of at-risk drug products for counterfeiting, those likely are going to be at risk for tampering and counterfeiting. You just go to the FDA's PDMA policy compliance guide, and you can see it here. As well, the list of current drug shortages, again, that's a high-risk drug because of the fact that there's large margins here. You can go to the ASHP site here, American Society of Health Systems Pharmacists, or the FDA website. Both of those provide up-to-date information about this stuff. As well, make sure sources will verify all the legitimate characteristics of the drug. If they have any hesitation of doing the right thing with respect to providing information of where the drugs came from, run, don't walk away from that source. Now, in addition, you want to detect this stuff, all right? And how you detect it, most of the situations, and this is actually building on some of the Institute for Safe Medication Practices material, and more recently, some of the stuff they talked about in the gray market. First and foremost, unsolicited sales offers that are outside the U.S., have a foreign number, no listed address, promising guaranteed availability of drugs in shortage. They misspell names. They offer generic forms when none is approved in the United States. Any of these things are indicia of a suspect group selling drugs. So importantly, in about 50% of hospitals are seeing a lot of these unsolicited sales offers either through the gray market or through the internet. Be aware. Be vigilant because these are the ones that are risky. Suspicious vendors, they ask for their wholesaler license, they don't have one, they want cash or in some cases PayPal. Refuse to pass a pedigree where the drugs actually came from or tell you where the drugs came from, and of course they offer a price that's way too good to be true. First of all, way too good to be true, but more importantly, the fact that they have the drug at all is maybe a very important sign that, wait, something may not be right here. In addition, what you want to do from our point of view is, as well, analyze the actual product. So you've gone through this other stuff, looking at the pedigree, looking at X, Y, and Z, look at the address, looking at all these different things. The job doesn't stop there. If everything looks good, you still have to assess what does the product look like, what does the packaging look like, what do the labels look like. It should be pristine. All these should be perfect. There should be no spelling errors. There should be no smudges. There should be no indicia of poor quality. Make sure you look and actually assess it. So it's a 2-1-2 punch. Make an assessment beforehand of the actual vendor. Make an assessment of the product as well. You want to make sure that that product looks right. Now, if you actually do discover something that you feel is suspect, now remember, you do not have to have a slam dunk case. You do not have to have something that you can prove to the point of a jury. That's not our problem. Our problem is if we see something suspect and we don't feel comfortable in giving it to our patients, we need to report this. So what we should do is report it. For suspect medicines, MedWatch, that's the FDA system, allows any and everyone to report problems with particular drugs there. For suspect vendors, the FDA Office of Criminal Investigations, they do a great job in looking and following up some of these leads on unsafe vendors and safe medicines and vendors. Also, though, yes, the FDA is an important place to report to, but also report to the National Association of Boards of Pharmacies and look at the place where, in fact, these people are claimed to come out of, what states are claiming to come out of, report these people to whatever state that they're claiming to come out of as well. Report them to your state that they're trying to sell you, because you want to make sure they're not going to sell to somebody else as well, or at least they're being assessed when they try to sell. Importantly, step 4 is this problem is not static. It's not going to go away. You've got to keep vigilant. You've got to keep educated. You've got to realize and focus on the fact that this is a dynamic situation. Human beings are behind the criminal activity. They're creative. They're always going to try to find new methods to try to get this stuff in front. For example, one of the critical areas that we've been seeing is that no longer do people actually search online using a search engine to get their drugs. Now what they're doing is they're using social media, Facebook, Twitter, MyLife, all of these things, Flickr. All of these things are now being used to try to draw people in because they're quote-unquote trusted, somebody friended you to do this or that. Again, these guys are very nimble. These criminals are very nimble at what they do. Do not let your patients be actually taken in by this. Inform them about it. Warn them about it. And as well, we should also do the same thing. We should not be taken in by these looks legitimate, but in fact, they're not legitimate sites. And there are a variety of internet sources you can go to, of course, webinars, but Safe Sourcing homepage, you have safemedicines.org, that's the organization that I work with. But the FDA has really outstanding information. The National Association of Boards of Pharmacy have outstanding information. And we really got to make sure that if we're acting as providers, we've got to take advantage of those things, because the last thing we want is any action on our part that harms our patients. Similarly, if we're a patient, we want to be able to go and say, listen, we are informed about this. We want to be partners with you, particularly, again, the pharmacist, critical player here. We want to make sure that that pharmacist coordinates with the patient, that pharmacist perhaps with a source coordinates with clinics, or if your in-house pharmacist is there, those people are coordinating everything. That's what you want, a person who actually knows the material, a single place to actually have the individual with all the information to make the assessments of whether this is whether the vendors are legitimate and whether the drugs are legitimate. So overall, I want to make sure people realize this is not theoretical precepts. These are real people. Maxine Brown, the patients in Ontario, Hamilton, Ontario, who died because of the fake Norvasc, Kim Fagan, Rick Roberts, a very good friend of mine here in California, HIV patient got fake serostin, and that was not good when you have AIDS wasting syndrome. Marsha Bergeron, I mean, all of these people are dead because somebody wants to make a profit off the most important therapeutic arsenal available in medicine. That's inappropriate. So overall, legitimate drugs, they are the tool for us. They are the arsenal that gives us the biggest bang for our buck. Counterfeiters are becoming big business for these criminals. Why? Because FDA drug shortage, other shortages, and there's a lot of money to be made here because that's where the money is. Pharmacists, remember that one person, let's have coalesce around that person. They're often the last barrier to patient harm. Educate and communicate with them, have them and us talk to our patients, and then we can actually ensure safety of the drug supply. All right, so that's completes my comments. I'm happy to answer any questions or give any answers.
All right, thank you, Dr. Liang. At this time, we'd like to invite the audience to ask our panelists questions. To verbally ask a question, please use the raise your hand function in the control panel, and I will unmute your line. You can also ask questions using the chat and question features.
Deborah, this is James, and while we're waiting for some of the other listeners to join in, I'd like to ask Dr. Liang to talk about the active pharmacological ingredient, and if we could better control the API, where and how it's distributed, would that help with the counterfeiting problem, in his opinion?
Oh, absolutely. If we could actually control where the API is coming and going, then we actually probably could do a better job of controlling it. The problem is we can't. Right now, the tremendous amount of outsourcing to a variety of places around the world to make these materials. So again, Europe, United States, a variety of other places, this stuff just gets traded left and right, and there are no real limits. Indeed, the Chinese, who are the #1 source of API in the world now, they actually say our state Food and Drug Administration, we don't cover drugs. That's a chemical manufacturing issue. That's not our issue, so we're not going to get involved in whether that's the manufacturing practice for patients, for medications or anything like that. So we have a tremendous start of international or global determinations of where API should be coming from, how those things should be, for example, tracked and traced, whether those things are legitimately being made for the domestic use or they're being shipped all over the place to counterfeiters. Unfortunately, we don't have a good national or legal regime yet to actually address that issue. People are making those assessments and making those proposals, including myself. But right now, I know this is a long answer to your short question, James. Right now, it would be great if we could, and it would really go after the problem pretty significantly, but we just don't have the cooperation now to be able to do it.
Thank you.
Okay, we have a question from Tom. Tom, I believe I've unmuted your line if you want to go ahead and ask. Tom, are you still online? Well, he submitted it written too, so I can ask it that way. How can we best utilize social media to disseminate alerts relating to counterfeit drugs?
Oh, that's a great question, and I'm interested in James's answer to this. My own answer is that social media is one of the most powerful tools there is out there, particularly in disease management groups. So, for example, HealthHIV, if they created their own, and they probably have their own systems of social media, what you want to be able to use is, number one, social media to identify the reactive measure. So you identify a problem with, let's say we've just determined that there is a problem with an HIV drug. We should immediately identify who the important groups are, like HealthHIV. And HealthHIV then sends out a huge, tremendous blast on the post, a thing on their Facebook page announcing it, get all their Twitter stuff out to other people, use MyLife, use a variety of systems, and you have to use all of them because everyone uses them in different capacities. But if you use basically 3 or 4 and blast the same message out, obviously relevant context with respect to the social media, that really is effective. And this has been used in other circumstances, for example, childhood safety and other circumstances, to be very effective in rapidly getting this information out. Obviously, there are other situations that we've also seen in terms of rapid communication, everything from Occupy Wall Street all the way through the Arab Spring. So social media has a tremendous ability to get information out quickly, and that's exactly what we want in counterfeits. So what we have to do, like for example, the MHRA, basically the UK FDA, has indicated there's a problem. They've identified a HIV drug in their legitimate supply chain that's fake. So that, as soon as that information gets to HealthHIV, it should be spread out, not only on their website, which is the traditional mechanism, but on all their social media avenues, because that will get everybody, or at least a lot of people. Very underused at this point, still underused at this point, the power of social media. The other avenue here is providers. Providers often are the last people to know that there's a problem with the drug. You've got to get the providers on board here as well, and that's also straightforward to do. Most specialty societies in the United States and around the world have their own Twitter, Facebook, MyLife, whatever, depending on the part of the world you're in. They too should be using that method and that platform to get out important information about counterfeits. So that's the reactive system. The proactive system, we can talk about that, but some of the things that we really need to do is start getting these kind of hash parties, these parties, these time periods where we actually talk about critical issues, community service events. All of these things can be used to actually try and educate patients, particularly when there's a bad result. And now we have a really great platform to start talking about this. I have in my community. The real thing right now with the FDA current drug shortage, huge. So many people are attentive to this issue, more than I've ever seen in the last 10 years with respect to drug supply safety. Now is the time we can actually get involved in this, and I think we can really build some good bridges here with respect to getting to those patient groups who are using social media.
Well, and Dr. Liang, you're right. HealthHIV, we use a blog, we use Twitter, we also have action alerts, as well as we have our own website, and we post alerts to the website, as well as we are linked through a partnership. Michael mentioned earlier the Federal Aid Policy Partnership that we distribute this announcement to is organizations with national organizations are all with the headquarters here in Washington, D.C. And so, with the touch of a button, you can send it all over the country. So it's a very effective tool. Not used an awful lot yet, but coming. We have to learn how to become much more proactive as opposed to reactive. But it's the reaction to an incident that usually garners the attention, unfortunately.
Yeah, I think that's right. And that's the kind of material that we use to get people's attention. Usually we do look at an adverse event, and that obviously is it's important for people to know. Soon, however, I think that as social media becomes much more prevalent and actually gets much in terms of being integrated into more professional communities, I think that this has a tremendous basis, particularly for activist groups like HealthHIV, for the groups that I work with. We want to reach our constituents, and our constituents hopefully have feel that there's a value to be reached. So they actually have been pretty good about allowing us to start working on this topic. But I think Health HIV, you've already started on that pathway. It's going to be exciting to see how the innovation from Health HIV and others can teach the rest of us how to best reach patients. Because I think part of the problem is that when we go into the healthcare community, if you're a provider, it kind of burns away a little bit of your remembrance of what it was to be a patient. And I think it's really important to always remember, hey, we are all patients. That's on every level. We got to remember that first. Don't give me jargon. Give me what I can understand, what the action is for me as a patient. That is so much more effective than, for example, just putting out. I've seen a lot of advertisements in newspapers. Watch out for X. These are warnings for Y. Public service announcements at 2:30 in the morning from the Ad Council. It's not really going to affect the patients that we want to affect. So I really look forward to seeing the development, James, on the Health HIV, because I think that's going to be an important population to really monitor.
We also have a question about whether or not a copy of this presentation will be available. We are recording this, and we'll be putting it up on the Partnership for Safe Medicine's YouTube channel, so you'll be able to watch the presentation and hear Dr. Liang's commentary and presentation as well. Another question that we have is, with the advent of advances in supply chain technology, such as RFID, are there any advances in point of service technologies?
RFID, yes, has been proposed as an important way to track and trace drugs. The problem with RFID is it's not ready for prime time yet. There's a lot of problems with RFID. Everything from technical problems. You're getting a 20 to 30% in some cases miss rate. You need to, for example, if you're one of the big 3 wholesalers, you're talking about 2 million packages going out a day. That's not easy to do with a traditional RFID system. So although people are moving in that direction, we're still not there quite yet. We still have a high error rate, and we still have tremendous challenges in trying to get people to do this effectively. Now, in terms of point of service, yes, there has been point of service advancements in technology, and that's actually being used right now in Belgium, although I think that's going to get canned because of the cost associated with it. But yes, there are systems very similar to the bar tag reading that we see in our grocery stores, but it's a little bit more sophisticated than that. However, the cost is just tremendous, and that's a real challenge for pharmacists who are in the community. The estimates are to do a really robust authentication and track and trace system. A single pharmacist would probably have to spend between $80,000 and $120,000, kind of depends on how big they are, where they are. If you're a chain, multiply that and say, well, it's between like $1 billion to $1.2 billion. These are all figures that are coming out from the industry, so we don't really know kind of what the specifics are. But suffice it to say, when you just talk to pharmacists, as I have, and I work with them, they're saying it's just so expensive that it's almost not worth it for them, because if the law changes in the midst of it, they just put all this money out, and it's not worth it to them. So RFID as a technology is getting there. And as that price goes down and the technology gets better, we're fine with that. One sidebar about that, there are some reports that biologics change their character when under RFID fields. That still has to be resolved. But even aside from that, we still have some technology problems. Yes, we had point-of-service testing, but as a point-of-service testing of the legitimacy of the drug. However, that's still going to be in the process of trying to integrate the technology. Of course, the final thing is who shares this data? Who owns it? Big problem with that. We don't know whether this data is going to be proprietary, whether this data is going to go from here to Europe and back, or where. I mean, there's a lot of classical kinds of geopolitical problems that we have to address when we're addressing the use of technology. But it's getting there. It's just right now, it's a little too early for prime time. Not really quite ready there yet.
Okay, and this will be our last question of the webinar. Is there a central clearinghouse of information that about present counterfeit drugs that warrants attention?
Oh, that's a really great question. The best place to go is the FDA website. You're not going to get the perfect, kind of complete, because obviously the criminals don't issue annual reports, so we don't really know exactly which ones that they're making out there. But yes, the FDA has sourcing as to what materials have been actually found to be either substandard or fake. great source. And as well, we at the safemedicines.org site also have a lot of warnings as to all the government issuances of warnings about counterfeit substandard drugs out there, not just in the United States, but around the world. So if you're interested just in the United States, perhaps the FDA site or the Safe Medicine site, if you just focus on that. For more international assessment, you can also go to the safemedicines.org website, and we have a lot of the stories about when these things came out, when did these drugs get reported as fake.
All right. Thank you very much, Dr. Liang and James, for answering questions today. This concludes today's webinar. If you have any additional questions, feel free to send them to myself at Deborah@safemedicines.org, and I can pass them along to today's speakers. Thank you again, and have a wonderful day.
Thanks, folks.
Thank you.
Thank you, Deborah. Thank you, James.